we are planning for full mouth rehabilitation for this patient. This is a lower jaw. Already lot of alveolar bone loss has happened. So natural alveoloplasty. Here we may do some kind of bone leveling here. If you see, the mental foramen is quite weak, right? Here the mental foramen is very much closer to the crest, very much closer to the crest. We'll see. You can see the severe bone loss and bone formation in some area. Okay. So this is a panoramic view. Okay. So we are planning for 8 implants. Anteriorly we plan first 1 implant anterior to canine in front of the canine. So the bone is very ideal. There is no curvature, nothing, because of severe resorption. It is straight now. Previously it would have curved like this, like this. Now you cannot make any mistake. Just straight drilling is enough. 4 into 12, 13 mm we can place. Okay. And another implant just anterior to the canine on the left side. So if you see the panoramic view, you will see the length from here to here. Okay, around 22 mm. But can you place this much? It's not possible because of the curvature here. So we can drill till this resistance and we can select an implant around 4 into 12 or 13. Okay, so this is the panoramic view. So by seeing the OPG, the doctor may think from here to here I can place a longer implant, but practically it is not possible, and it is dangerous also trying to do it. See the thickness of cortical bone. It's around 6-7, right? But we are not going to drill it. Okay, just we are going to use the intramedullary bone. Now we are going to place 1 implant on the first premolar area. Okay, this is the left side. So this is the active infection side. We have to do curettage. So here also you will feel the resistance here. Okay, so same 4 into 12 or 13. The only thing is we have to. So here the mental foramen is safer only. Okay. So the mental foramen is in between the second and first molar. Okay. And we are planning implant in the second molar. We are not going to place, but our implant. This is the area in between the 5 and 6. This is a very excellent area to place implant. So the mental foramen is here. Lingually you are safe. Around 10 mm implant you can place. If you do alveoloplasty for 1 or 1.5 mm, you can place definitely 4 into 10. Okay. And the last implant will be in the distal root of 6. See the calculus, how much radio opaque it is, right? Like an extension, like a clasp. So along the lingual socket wall we can place, and it is better to get a lingual engagement here because the intramedullary bone quality is not very good. Here it is fully black. Only here it is somewhat okay. So getting lingual cortical engagement will be more advantageous. So if you do a little bit of alveoloplasty, you can easily place a 12 or long 0.5 mm implant. We'll see what it is 60 mm. Let's do it. Just we will check the 7. Okay, it is not needed. Why to complicate the situation? Okay. Now we are going to place in the 3-4-4 region. Okay. Just distal to canine. This is the mantle foramen. It's away from mantle foramen because obviously it is in the first premolar area. The moment you go into the second premolar, it becomes close. We'll check the second premolar. Initially we saw the foramen is very much closer to the crest here. It is better to avoid the second premolar here. So we are just going just in between the mesial root or just in front of the mesial root. Okay. Now we'll see the 360 degree. Now if you see here, it is closer because of severe resorption is there in the 6 area also, not only in the 5. So if you place 10, you will be entering the mental foramen and canal. So better to select a 8 mm implant. Okay. If you place implant in the mesial root, then the inter-implant distance will be more. So we will be placing implant anterior to the 6, but we are selecting a shorter one. You can see now this mental foramen is extension. Now we will see the distal root of distal root of 6. See how the calculus is deposited, no? Like in links. Here the canal is a little far away. Here it is better to get a lingual vertical engagement. Okay. Here we can place a 10 mm implant. Here we are not going to do any kind of alveoplasty because the bone is already lost till the apex. Almost 80 to 90% of the root is outside, right? So we have enough of prosthetic space. Here the abutment will come, here the process will come. Prosthetic space is there sufficiently for this patient. So alveoplasty part we don't have to waste time here. We are saving time by the already happened bone loss. It's totally 4 implants. Distal root of 6 is the distalmost implant. Okay, that is our term point. Sometimes we may plan to use 7 also if the 6 is in trouble. But here up to 6 decent bone is there. Even if you want to use 7, we can place a good 8 mm implant, lingual cortical engagement. This is a backup. Okay, the 7 area in this situation is we can keep it as a backup. Here it is not ideal, the left side, it's not very much ideal. You can place a 8 or 10 mm implant.